Just going to give it a minute for people to join us from the waiting room before we get started. So we'll get started at 7:01. Perfect. So thank you for joining us tonight for our first 5 years community of practice. I'm Ryan Bannock. I'm going to be moderating the session this evening. This evening's session is going to be on expanding horizons, balancing comprehensive and focused care. Next slide, please. So a bit of a land acknowledgement. We wish to acknowledge that this land on which the University of Toronto operates, for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Next slide. So the first 5 years community of practice, it is designed for you in your first 5 years. Free, fun, and full of answers. These are accredited for 1.5 main pro credits per session. So please remember to put those in your account at the end of the evening. As well, we've been doing fun pairings throughout all these sessions that we run monthly. So tonight's snack pairing, if you brought it along, is guacamole and veggies. So Eleanor College is my co-lead when it comes to the early in practice CPD, and she'll introduce herself in just a few moments. I'm Ryan Bannock, and I'm going to be moderating the session. I'm the early career supports lead the early career supports lead in the Office of Health Systems Partnership and a family doc in the Jane and Finch area. Why don't I turn it over to Eleanor to introduce herself as well?
Sure. So hi, I'm Eleanor College. I'm a family doc in East Toronto, work at the Southeast Toronto Family Health Team, and I'm the CPD program director at the University of Toronto, Department of Family and Community Medicine, and really thrilled that folks are joining us tonight.
Perfect. So the first 5 years community of practice, in terms of disclosure of financial support, we don't have anything to disclose. And just to let you know that there is a scientific planning committee that has full control over the choice of topics and speakers, and we have developed content according to the standards and expectations of the main pro certification program. The content was reviewed by a 3-member national scientific planning committee. Next slide, please. So just before we turn over to the panelists, I'd like to thank everyone who is joining us today as we compete with the Leafs game. So we know we may have lost some people along the way due to the Leafs. Maybe they're a stronger pull than this, but why don't we turn it over to our 3 speakers? So why don't we first, Preeni, if you can please introduce yourself.
Hi, everyone. Nice to see all of you. My name is Preeni Rathuge. I'm a family doctor in the Scarborough area, and I'm also a surgical assistant for Scarborough Health Network.
Thank you. And Anthony, you can introduce yourself.
Hi, everyone. Good to see everyone on Zoom, and thanks for sharing this hour with us. My name's Anthony Davies. I am a family physician at the Summerville Family Health Team, where I practice as an academic, a comprehensive academic family physician, and I have a number of roles teaching undergrad, medical students, and residents, and also some areas of focused practice. I have no disclosures. I'm not sure if it's the time for that. Yeah, thank you. No conflicts of interest.
Hi, everyone. I'm Sheniz Eryuzlu. I'm a family doctor working in North York, and I also do sport and exercise medicine in East York.
Thank you so much. So why don't we advance to the next slide? So if we can go again and just give our disclosure. So we'll start with Preeni.
Yeah, I don't have any disclosures for today's talk.
And Anthony?
Neither do I. No conflicts of interest, no disclosures.
And Sheniz?
Me neither.
Perfect. Next slide. So I do have some disclosures. So I do get a speaker's honoraria from the Ontario Medical Association for some work I do around billing and practice management. I'm also on salary from the Department of Family and Community Medicine, Office of Health Systems Partnership. I also do get, I guess, honoraria from the Section of General Family Practice, where I sit on the tariff committee. And I should also add on, I also do get a stipend from the Northwest Toronto Primary Care Network, where I serve as the co-chair of the Primary Care Network. Eleanor? But none of those actually pose a conflict for tonight. Eleanor?
Good, yeah. And I have a few disclosures just in terms of work I do with the OCFP with the other community of practice. And also I do work for the DFCM, and I do some work with the Foundation for Medical Practice Education. But nothing's going to pose a conflict tonight.
Perfect. Next slide. So all questions, please put those in the Q&A. For the chat, if you guys have something to share, you do focus practice, you do something in your practice, the chat is literally to chat, to put out ideas, converse with your peers who are also here attending the talk. But any questions, put in the Q&A. If there's a question you ask, please upvote it, because at the end, when we take the questions, I'm going to first choose the ones that have been upvoted first. Next slide, please. Okay, let me turn it over to Preeni.
Okay, so yes, as I said, so I'm a family doctor in Scarborough and a surgical assistant, and just hoping to take a little bit of time today to share sort of how I balance those two hats and share a little bit about what a week in my life looks like. Next slide. So my primary role, so I'm a comprehensive family doctor, and I have a faux practice of about 1,000 patients, and I work about 6 half days per week in my office. I'm part of a big distributed faux in Scarborough, so we have about 30 other doctors, but my office itself is just me and one other colleague, so small office. And that's sort of my main hat. And then my side gig, as I like to call it, is I'm a surgical assistant, and that's at Scarborough Health Network. And I do that 2 half days per week, plus 1 to 2 call shifts a month. I started assisting about 3 years into my family practice, and I've been in family practice for about 5 years now. And my primary assisting role is I do ear, nose, and throat assisting, so mostly thyroid and parathyroid surgery. I also wear a couple of other hats that I juggle. So I teach for the Scarborough Family Medicine Residency Program, and I'm the co-QI director for our QI curriculum there as well. Next slide, please. So a week in my life is pretty busy, but I like to think that it kind of all flows nicely together. So Mondays and Tuesdays, I'm in clinic morning and afternoons. Wednesday, I do a morning clinic and I leave the afternoon free, and that's kind of my paperwork, my catch-up time, or if I need to, some time off. Thursday is my elective assisting day. So this is when I'm in the ENT ORs at Scarborough General usually. And if I'm on call that week, I tend to do call maybe once or twice a month. I typically try and add that on to a Thursday shift. Friday, I have clinic in the mornings, and usually that is my resident supervision morning. And then I like to leave the afternoon off to catch up, or if I've had a busy night on call, just some time to get a little bit of rest. Next slide, please. So why did I kind of land into surgical assisting after a couple of years of being into family practice? I mean, I really loved my family practice, but I was kind of looking for a change of scenery, and I wanted to find something that would fit nicely with my family medicine practice. And during COVID, an opportunity kind of came up to try surgical assisting, and it kind of just fell into my lap. I had always kind of liked surgery, sort of in medical school and in residency. I enjoyed my gen surg rotations. Yeah, it kind of just sort of fell into my lap, and I tried it out and I really ended up liking it. In terms of sort of balance, like surgical assisting fits very nicely into family practice because there's like quite a lot of flexibility, especially at our community sites throughout the Greater Toronto area. So I basically tell them what my availability is, and then they book me if they have cases that day. And otherwise, you know, I can spend that time in my clinic or doing other work. It's been very nice in terms of sort of developing surgical skills. Like that's not really something that I get to do very often in my family practice life. So, you know, being able to do things like suturing and closing, like that's been a lot of fun. It's unlike a lot of sort of other opportunities that kind of come up alongside family practice. There's no formal training that's really required for surgical assisting. It's usually like a mentorship-based role. So you shadow other surgical assistants at your site and sort of gradually take on more responsibility. So that made it sort of easy for me to jump into it even a couple of years after I'd been out of residency. Also, like I think another sort of thing that I've really enjoyed while I've been assisting is building relationship with my specialist colleagues. So it really makes it easy when you are referring your patients to colleagues that you're working with in the OR. You know them personally, you understand how they operate, and it sort of makes that transition for patients quite seamless. Another part that I really like about surgical assisting, like there really is no paperwork. So, there's no pre-work that I do before I go in the OR. There's no post-work that I do after the OR. So it leaves sort of my brain free to kind of deal with things in my family practice as needed. And I really think that it's kind of made me love my family practice more. I'm lucky in the sense that I get to assist in the community that my practice is also in. And so it's nice to be able to be in contact with patients at different parts of their healthcare journey. So for example, like in my, I think it was like 3 months into surgical assisting, I had a clinic morning and one of my like 90-year-old patients missed an appointment. It was kind of like unusual for her. We called her and we couldn't get a hold of her. And I just kind of like left clinic being like, I wonder what happened to her. And then I show up for my call shift. And unfortunately, she had just been at her gynecologist's office in the morning and fell off the exam table and actually broke her hip. So she was in the queue for getting a bipolar hip replacement that day. So as unfortunate as that situation was, like the patient really appreciated the fact that I was her family doctor and I was there that evening operating on her in an emergency. The family was really appreciative because they knew that I sort of knew her history and was able to communicate with the surgeon, and it just made follow-up really easy. So I've had the chance to be able to operate on some of my other patients, like some people who've been diagnosed with thyroid cancer. So it's just been really nice to be able to like add that into my family practice. I think patients appreciate it, and it certainly makes me like my family practice even more. Next slide, please. So I mean, there are some challenges, of course, like surgical assisting, like especially when I first started it, like there's a learning curve, right? And the amount of cases that you do matters. But being on call frequently kind of helps with that. It also takes some time to sort of find your niche. There are some surgical assistants that like to do all different types of surgeries. I sort of prefer to sort of find the area that I liked and really develop my skills in that area, but to each their own. And then the other thing in terms of balance that can be challenging is call, of course. It can be quite lucrative. In terms of how I balance things, I like to try and fit my call shifts in during the week and on days where I'm already in the operating room. So it's a little bit easier for me that way. The other thing that's nice is that I'm part of a big group of surgical assists, so there's about 50 of us, so we typically only have to take call once or twice a month, so I find that that's fairly straightforward to balance with my family practice. Next slide. And this is me in the OR last week, so we're doing some ENT cases. It's just like a nice change of pace from my clinic, and we have a lot of fun. The patients are asleep. It's like a nice chill day usually, so we have a good time. Next slide. And if you're like thinking if this is something that you might be interested in, because it is one of those things that you can kind of do even after you're done residency, like most community hospitals outside of the downtown core rely on family medicine assists. So you can reach out to the chief of family medicine or the chief of surgery at your local hospital to see kind of what opportunities are available. And as I said, like it really is like a nice complement to family practice. Next slide. I think we're going to save all the questions to the end, but happy to answer any questions. You can also reach out to me by email after this if anything comes up. Thank you so much.
Wonderful. Thank you very much, Dr. Rathuge. I'll take this as a cue for me to go on. So I'm kind of telling a story with my own experience in early practice as a physician, where I had my medical degree at the University of Lagos, and that's in Nigeria, and practiced in Africa for about 3 years. I haven't gone through, you can see me now, practice in Nigeria for 3 years. I've been going through what we called a rotating internship, and did another extra year in anesthesia, graduating with a diploma of anesthesia. And upon practice in Saskatchewan, I went through the family practice anesthesia route again. So I did another additional year in anesthesia. Also spent, sorry, the times are not quite there, but that was around 2015. And in about 2020, I went for further studies in a master's in pain management, while at the same time maintaining a clinical practice. So what I have to share on this slide is start where you are, use what you have, and do what you can, emphasizing that really is your expectation of yourself is very important to kind of get that expectation managed so that you can realize your full potential and that concept of good enough. Next slide, please. And I've practiced in different settings in rural Saskatchewan and Ontario since coming to Ontario in 2018. Practiced also in a small community in Ontario in Listowel as a GP anesthetist. At that time, there was a need for addiction medicine and pain management because Listowel was a hotbed for fentanyl. So I also did additional training in that and actually got my added competence in addiction medicine through a practice eligibility route. I do some psychiatry, managing inpatient at the CAMH. These shifts come up as few as many as they come up, and to keep my privileges, I volunteer for probably 4 to 6 throughout the year. So these are all spaced out throughout the 52 weeks of the year. And in family medicine, based primarily at the Mississauga Family Medicine Teaching Unit. I do have privileges in the hospitals, but I've over the years kind of fallen back on that. But I do enjoy my academic role, teaching undergrad medical students in their courses, portfolio courses, and health and communities research courses, and also precepting postgraduate residents. Next slide. And teaching is what I love very much. It actually gives me joy in medicine. It gives me that boost of energy, like the previous speaker said, that to find joy in what I do every day. And I have went further to enhance my academic skills by being involved in research with others, and as well in my own ability myself, having attended speaking functions at universities in North America. And I quote here Jack Barzun, who says, "Teaching is not a lost art, but the regard for it is a lost tradition." And for thriving through the various changes that having a comprehensive practice, as well as also nurturing a focused practice. Resilience is probably a word I can't overemphasize. When I came to Canada, I had to pretty much retrain to adapt to a different healthcare system. And in my practice, I'm oftentimes switching between different roles as a family physician and a rural doc, a rural emerged doc, where you really have to put on your best thinking hat and really be able to manage complex cases, especially when I work in the northern communities that I frequent a couple weeks of the year in Kirkland Lake and Wawa. So it's really a challenge balancing, but over the years I've found found a way to kind of integrate my work and my life. So I have it as fun, take my family along with me when I go up north. And we do enjoy vacation periods where I'm also working in the hospital and working in the OR, putting folks to sleep, coming back home, and doing some fun things. So that's how I balance it. And in terms of another role that I've also looked to develop is leadership. So I do get involved in the Ontario Medical Association through my presidentship in the Kitchener-Waterloo Academy of Medicine, and have active roles as peer reviewers for publications, one of which is the McGill Jordan of Medicine. And I see leadership not as a title, but as something that I can bring my own abilities, my own perspective to the table, and lead by example to be a good role model. Next slide. And in terms of balancing the academic practice, my comprehensive practice, and the focused practice, I take an integrated approach by balancing the different aspects of what I do and teaching to deliver a well-rounded care. So I always feel like what I'm doing is taking a holistic care of the person, considering, their biology, their psychosocial, and of course, environmental factors that may be playing a role in health and disease. And very importantly, I also manage myself by prioritizing my work, planning ahead, planning weekly, and making some protected time for myself to achieve my various roles. Another aspect that I found very helpful is delegating. So delegating others to do things they are comfortable to do, and that gives me time to do what I really like to do. So I work with, for example, a nurse practitioner or physician assistant that are able to work with me under supervision to see patients, give injections, and then I'm less occupied with those routine tasks. And they answer to me, of course. And I use digital tools, use an electronic medical record. I love doing that. Use AutoScribe, and I also use digital scheduling tools. And I do have a secretary that helps make sure my schedule work out very good every day, every week, every month. The outcome, of course, is efficiency and being purposeful and making sure that my work, what I do, can be sustainable, because I do plan to continue working until 80 years. Thank you. Thank you for that. And also, the other aspects of my life, of course, I'm a father to 3 boys, so I still have to make myself available to them, to take them to their soccer practice. Personally, I play soccer. I love playing table tennis, and so balancing that aspect of my personal life, family life, and my work is something I thrive doing, and I hope I can encourage others to pay attention to these aspects as well. And yeah, what I wish I knew early on would be, keep learning, but trust your training, protect your time and well-being. There's always a lot of demand on my time and well-being. So learning to say no, and not just taking roles for the sake of it, but really making sure that I'm leaving a lasting impact in whatever I do. And in terms of success, for me, it might be different for every one of us. Of course, our paths are usually not linear, but take your strengths as your compass, and do not let anything steal your joy by comparing yourself to other people, because your race is individually yours and unique to you. So enjoy the journey. And further advice, of course, stay connected. You can reach me by email or follow me on. I don't usually active on social media, but I do have a website as well, and I'm always happy to give my 2 cents on on issues that people may ask me about that I have experience in. Thank you for this opportunity.
Thank you very much, Anthony. Why don't we turn things over to Sheniz?
Hi, everyone. I'm Sheniz. So I'm going to be talking about my practice in family medicine and sports medicine. Next slide, please. So just quickly, my background in education. I did undergrad at U Ottawa, then I did med school at Mac, family medicine at U of T, and then also the sport and exercise medicine enhanced skills year at U of T. So this is a summary of my weekly schedule. So I work in a faux practice in North York. I'm there 2 full days a week. And then I'm in my sports medicine clinic in East York, which is on the Danforth, 3 days a week. An overview of what my sports practice consists of. Basically, there's 2 main routes that patients come to me. One is through Michael Garron Hospital ER referrals, where we see more like acute referrals, like post-dislocation sprains, acute tears, OA flares, gout flares, all these kinds of things. And then the other main route would be via family medicine referrals, which often have been like worked up already, potentially more chronic cases, maybe like MSK pain that's not quite diagnosed, or like chronic low back pain or chronic shoulder pain, like that kind of stuff. In terms of the patient population that I see in sports medicine, it's a huge variety. In terms of age, it's every age from kids all the way to very, very senior. Kids is often more acute injuries. Seniors can often be more like OA, that kind of degenerative stuff. And in terms of like sport profile, it's also the whole spectrum. So a lot of it, I would say at least 60% of the people I'll see in a week are general population who have like OA or sprain their ankle or have frozen shoulder or just like rotator cuff tendinopathy. And then the other part of the people I see are athletes, anywhere from recreational to professional. If I had to summarize basically what sports medicine practice consists of, at least in clinic, I should say, this is kind of this 5 main points. So first is number 1, just establishing do they have the correct diagnosis? And then number 1, is it going to be non-operative, operative treatment? Operative, then I would refer. If it's non-operative, then I make sure we're optimizing everything possible. That can be ultrasound guided injections, which I would offer. That could be referring them to anyone in our R or A multidisciplinary team. So PT, massage, chiro, bracing, orthotics, medications, sometimes ortho, or even referring to other specialties altogether, like rheumatology, neurology for EMG, or like pain clinics. And then just a quick note on the injections that it can entail. These would be kind of the summary of the common ones. So rotator cuff is very, very common, and any kind of tendinopathy or bursitis. OA would be very, very common after that, other than just anything axial, so any other joint or tendon, essentially. Frozen shoulder, plantar fasciitis, trigger finger, all that kind of stuff. And this is a picture of the ultrasound that we have in our clinic to do the guided injections. Now, in terms of getting to a career in sports medicine, there's 2 routes. One would be the sort of, I guess, what you would think of as the classic route, where you go through your family medicine residency and then you do the enhanced skills year. And then you have your diploma of sport medicine from challenging the CASM exam at the end of your year. The other route, which is also definitely done, would be the practice eligible route. I think that's the term for it. But basically, you do your family medicine residency, you graduate, you start practicing in family medicine, but you try to kind of cater your work to include some sports medicine work, maybe through word of mouth. You tell your colleagues that you'd like to get referrals for sports medicine cases if you have the confidence and competence to start seeing some more MSK stuff. And then you build up your experience and your billing code history in sports medicine codes. And then you can challenge the CASM exam. I think it's 2 or 3 years later. And then you can get that DIP Sport Med title if you want to have like a formal designation. In terms of what a career can look like, other than clinic, which we touched on, the other aspects would certainly be an event coverage if you want to. That could be anywhere from, like, for example, being the doctor on site for like varsity sports teams, or you could cover like the local marathon events happening in your city. Or for example, if like bigger events come to your city, like the Pan Am Games or the Olympics, FIFA, any of that kind of stuff. Or sometimes if you want, you can be the team doctor for a team, like for example, Toronto FC, and then you cover all of their home games, or the Toronto Maple Leafs, you cover all of their home games. Or sometimes you can travel with these teams if they qualify for like large international tournaments or games as well. And then some sports doctors also will do other stuff outside of these two things. They might do surgical assist because of the interest in MSK. They might do ortho surgery. Some people do family medicine like I do, and some people do even like rural emerge shifts as well, or walk-in clinic, I should say, as well. So I tried to think of some challenges in terms of balancing these two types of work. So one, I definitely would say is the event coverage aspect. If you wanted to be a sports doc who does cover games, that is essentially usually evenings and weekends. But then if you wanted to travel, of course, for like, let's say a tournament or a championship outside of your city, then it is a little bit of a balancing act if you also have a family practice in terms of being away, or potentially if it's a long time needing to hire a locum, like that kind of thing. So that balancing act can be tricky if you have a foe, depending on how much you want to be away, or how much event coverage you want to commit to. I personally don't do event coverage where I'm committed to a team for like a whole season. I will just do like sporadic event coverage. If somebody asks me to do an event and I think it's interesting, then I might do like a weekend shift or something like that. Another challenge, I guess you could say, is remaining up to date in two different specialties, especially with sports medicine. There's always, not always, but there's more and more evidence coming out for like certain injections and medications, and like more evidence in terms of like surgical versus non-surgical treatments, what's the best option depending on different cases. So plus, you know, all the evidence that always comes out for family medicine. It can be a lot to stay on top of, but if it's interesting and you love it, then it's always of interest to stay on top of it anyway. And then the third thing I would say would be accessibility to patients for both of the types of practice. So especially with a foe, like the main thing is the outside use. I would say in my practice, the way I balance it is my family practice is relatively small. I have about 760 patients. And when I am there for my 2 days a week shifts, it's pretty like packed full days. I do that by choice and by design so I can have a nice full 3 days of sports med, because I do love both jobs. I don't want to trim down either one really more than that. So yeah, I guess in terms of making sure you have good access for both sets of patients, it's really just a balancing act, and making sure that you're seeing enough people per day, or people per week that you feel like your waiting time is good for both. And next slide. And then why do I love doing both? So other than what the actual clinical stuff entails, which I love both types of work, the logistical aspects and practical aspects, one would be the two different payment models. So the sports medicine work is all fee for service. The family medicine work for me is faux capitation pay. So it is a nice balance, because if I want to go on vacation for a week or two, I do still get some payment from my faux capitation work. Whereas sports medicine, when I'm off, I get no pay. Same thing for example, mat leave or parental leave. Depending on how much your capitation is and how much you pay locum, sometimes you still get some pay trickling in from your capitation pay with a faux. Whereas, of course, with sports med, if you're off, no pay. Vacation time is a little bit different as well. for sports medicine, technically it's more flexible. Like you could leave for longer at a time. Patients don't necessarily need to see you like super, super frequently. Whereas family medicine, like, you know, if you're gone for more than maybe 2 weeks, it's probably expected and necessary that you have to hire locum. So a little bit more restricted with the vacation time and how many vacations perhaps you take within a year. So nice to have, I guess, a little bit of that variety. In terms of paperwork, difference is there for sure. Like, of course, family medicine has the inboxing work, whereas sports medicine is essentially no inboxing. Any results just comes to the admin and then they just book the patient back in for follow-up and then I just see it when I see the patient. So kind of nice to have like a second job that takes up a chunk of my week that doesn't also contribute to inbox and paperwork time. The patient populations can be quite different. Even though I said, yes, the sports medicine can entail the whole age range spectrum, often it is patients who have a high motivation to exercise and have a healthy, active lifestyle, which sometimes is a nice balance compared to family medicine where I have a lot of diabetics in my practice. So often I'm trying to counsel and encourage patients to have an healthy, active lifestyle, where in sports medicine, I'm often having to do the opposite, asking patients to, you have to take this amount of weeks off, like to, you know, let your injury heal, that kind of thing. So sometimes it's like the opposite conversation with patients. So it's kind of nice to see the different lifestyles and types of people and different motivations and that kind of thing. And then I would also say it is nice to have a difference in scope in the sense of being a generalist, but then also having my own little niche of being a quote unquote specialist. I think that balance is really fun and feeling like I'm a mini expert in something while still being also a family doctor and being proud to be having like a wide scope of practice there. And it also kind of gives me like a cognitive change up within my week because I almost basically alternate jobs every day of the week. So I can't really feel like anything's too mundane or get bored of any job because I just go to the job, leave the next day, don't come back. And so I'm constantly feeling like my brain's mixing it up and also like physically because the family medicine work, you know, is more cognitive sometimes. I'm looking things up more often. I'm learning new things more often, whereas in sports medicine, it's pretty algorithmic for me. So it's more niche, but then sometimes I get to do injections. So it's not all thinking and talking. So again, it just gives me more variety in what I do. And that's it. Thank you.
Thank you, Sheniz. So why don't we get all of our panelists to bring up their, I guess to turn on their cameras, and we're going to take a couple questions. So thanks so much. Anthony, if you don't join us as well, perfect. Okay. So a couple questions. So I guess our first question is, Anthony, if you can actually just share an example of your weekly schedule with like AMs and PMs. So how many days do you really spend providing comprehensive family medicine versus your other jobs, if you can lay out your week for us.
Wonderful. Yeah, it's different from week to week, but my schedule is built around my work in the family medicine teaching unit. So I have 2 half days where I teach, and that's usually on a Wednesday afternoon and a Friday morning. So I block off those times. And then I have time I spend, of course, with patients. My situation is also unique because I have some practice in Kitchener-Waterloo and a practice in Mississauga. So, and I usually don't work on the Mondays. So yeah, leaves me with a few days from week to week where I kind of catch up on seeing patients in Mississauga and in Waterloo. But typically, Mondays I use for my own protected time to do work, read papers, and do my write-ups for my work publications and drafts and all that. So Mondays are kind of that. I do from time to time get urgent tasks and follow-up stuff. So have to follow up on that, of course. So Tuesdays, I do virtual. In the afternoon, in the morning, I'm seeing patients in Waterloo, and in the afternoon, I do virtual, seeing patients on my roster. Wednesday mornings, I'm usually in the Mississauga, seeing patients in the family medicine teaching unit, and in the afternoon, precepting medical students and residents. Thursdays, I have more flexibility, and it's usually when I pick up a shift at one of the dental offices to do GA, and that list can be different each week. A couple of weeks ago, it was GA right in Mississauga for mastectomies. And another time it could be dental, or it could be general surgery, something else. So yeah, and Friday mornings, like I said, I'm in the family medicine teaching unit in the morning. Friday afternoons, I'm in Mississauga seeing my patients. My weekends, I try to keep for myself and for my family, but that's usually when I also pick up a shift in Toronto at CAMH, where I do some hospitalist work. And typically it's later in the year that I go with my family to Kirkland Lake or Wawa. I usually spend a week or two there, mainly doing rural northern work in the emergency departments, inpatient, and of course, anesthesia. So yeah, it's kind of different, but yeah, I work around it. Thank you.
Perfect. Thank you so much. We have another question for all of you. How large are each of your full rosters? So I guess if, why don't we start with Preeni?
Yeah, so my full roster, I have about 960 rostered. I have like about another 150 unrostered. Yeah, I find that that's sort of like the perfect number for me. Like I have 6 half days a week. I like to see people in person, and my clinic is close to where I live, so I'm in person every day. Yeah, my outside use is not too bad. My patients have started to just get used to the fact that I'm not there on Thursdays, because now it's been a couple of years, so they just know that I'm not available that day, and they tend not to make too much of a fuss about it. And I can also do quite a bit of catch up when I'm like in the OR. There's downtime between cases, so I'll do inboxing between then. My admin staff are awesome, and they, can field a lot of stuff themselves too. And yeah, and kind of make it work that way.
Perfect. And Sheniz?
My roster is 760. I can kind of bleed into that second question too about like the after hours and how's the outside use stuff. I would say like to have 760 and to work 2 full days is kind of like at the cap of what would be feasible. I think the way I do make it work is because the days I am there, I am seeing a lot of patients, maybe more than average, like I don't know, maybe somewhere between 25, 35 patients a day, including like I do 30 minutes of phone calls while I'm eating lunch. And then I have like a truly like a 30-minute actual break. So I kind of try to do a lot when I'm there for those 2 days because I don't want to cut out a day of my sports med. Um, and in terms of accessibility, like I really just titrate how many people I see in a day based on how I see my wait time is. Like I basically keep my wait time to about a week, and that also includes at least one same day urgent slot per day. If I see that my wait time's getting more than a week, then I'll shorten some patients and just, add in a couple more same day urgent slots. But yeah, it is like busier than average, I think, because that's just like how I've designed it. And so because of that, my outside use is good. But realistically, some people might work like if they had my schedule, they might work 2 days sports med, 2 days or 2.5 days family, with a little bit extra buffer, so the days are a little bit slower.
Thank you. And Anthony?
Yeah, and similarly, yeah, access is always a concern, and it's balancing the patient load and making yourself accessible. So my practice is larger, so I have about 2,000 patients, but also have the help of a nurse practitioner, physician assistant that I pay out of my roster fees and fee for service, so that makes it more manageable. And I do have, I do the hospital work and have support when I do that. Yeah.
Perfect. So I guess a few of you touched on it already, but are there challenges with after-hour clinics or picking up an after-hour clinic, but you have to be in the OR or something like that? Or have any of your colleagues gotten frustrated because they see a lot of your patients, for example, on a Tuesday or a Thursday when you're not in? Someone can jump in and speak to that.
I guess I'll touch base. Like the nice thing about my FO, and again, like this is sort of like the way that you engineer your work, right? Like I have a really big FO, so there's 30 of us, right? So in terms of how often I have to be on call for like after hours for my family practice, it's not very often. And then again, like because I've kind of purposefully kept my roster small, like I don't have a ton of outside use because like, and I'm there the other 4 days of my week, right? And I keep about 5 same-day urgent slots every day. If I'm there a full day, otherwise it's 3 if I'm there a half day. So I try and sort of work around it, and try not to be sort of too much of a burden to my colleagues. But like realistically, like with the schedule, the amount of time that I'm in my family practice, it's not too much of an issue for me.
Thank you. So why don't we move on to the next question? So if anyone has a focused practice designation through the OMA in their area of interest, how does receiving referrals work? And I'll add on a bit to that. Is there a concern with access bonus negation when you're taking referrals from colleagues, both within your larger FO, if you have a large FO, or even outside of the FO for other doctors?
I can speak to that. So yes, it is a little bit of a tricky process to get the special focus practice designation. Basically, the whole purpose of it is um, if you are billing family medicine codes that are considered in basket. So if you kind of think of it as like things that a family doctor should be able to provide as a service. For example, one of those would be like just like the counseling code or the non-complex joint injection, the G70, which is like a knee injection. So if I, for example, was to bill that in my sports clinic without the designation on a patient whose doctor isn't a FO, then that FO doctor will get penalized because it's, I guess the idea is like they're seeing another family doctor for a family doctor type service. If I don't have the designation, it's fine if I bill the codes that are out of basket, which are, I guess, more specialized, like the complex joint injection or a consult code that does not affect a FO doctor. But yeah, if you want to be able to bill even those in-basket codes without affecting FO doctors who might be wanting to send you referrals, then you need the focus practice designation. To get it is a little bit of a tricky catch-22 process because you have to have proven you've had like 6 to 12 months, I think it's more like 12 months of billing history of, let's say, sports medicine billing codes and diagnostic codes. But it's a little bit tricky to get those codes billed under your belt. But you have to avoid like dinging faux doctors. So you might have to try to get doctors who are not in a FO to send you referrals so you can see the consults, do MSK stuff, build up your billing history. And then when you have your practice designation, then you can go ahead and advertise to FOs, I'm open for referrals. So that first year is a little bit annoying in that sense.
If I may add to that, in my case, when I do, sorry, my kids are up night because we're in Africa and they're on a different time zone. In my case, I do my work in institutions that allow me to bill for hospital codes, so anesthesia in hospital codes or outside facility, outside hospital facility. So it's really not a problem for me.
Thank you. Preeni, you alluded to this earlier, but I'd love a take from the other two speakers. How you manage your inbox on days you're not in the clinic? If things come in urgently, do your colleagues cover? Does someone reach out? Are you still looking at your inbox even if you're not in your family practice? Sheniz or Anthony, do you want to take that one?
Sorry, can you say that again?
Sure. In terms of your inbox on days you're not in your family practice, how do you manage that? Do you take a look at it when you're not in your family practice, or if something's urgent, does a colleague cover it, or does someone reach out to you? I know Preeti mentioned between cases in the OR she looks. So I mean, unless you have more to add, Preeti, I'm happy to hear more from you always. But I think you had already covered what you do with your inbox.
Yeah, I do look at it a lot when I'm in my sports clinic, especially because I book patients like longer appointments, like consults I book 30 minutes. Often I don't need the full 30 minutes. So I'm often doing like a few tasks here and there between patients. And then yeah, for sure, if my front desk messages me something, I can very easily address it. Um, Especially if it's like let's say the like it's a day of the week where I'm in sports clinic and I don't have any other family clinics for the rest of the week, and it's like maybe an urgent thing. I just tell them to book them in with the after hours clinic. And sorry, to go back like a couple questions ago, one other quick thing about the outside use is it's first of all very reasonable to not be available 5 days a week. But that's the point of having after hours shared coverage as a group. Part of it, you just have to train your patients like this service is for you. We are working these shifts for you. So you should be making use of them, these shifts. And I feel like that's a big part of also why my outside use is good, because I'm not always seeing my patients, but that service is available for them and they need to know that it's every day.
Yeah, and if I may add, for me, that's also one I use my nurse practitioner and physician assistant to delegate to them. My unique situation is I often get HRM from different hospitals I've worked even years ago from. I get reports for patients about that. So I do have to constantly take note of that, but it also helps to have somebody who's looking at it and know what they can take action on or what they can forward to me. And right now I'm in Africa and I have access to my EMR as well. So I'm able to see my inbox and keep it manageable.
Perfect. Thank you so much. And I just want to echo what Sheniz said for our early in practice on the call here tonight. There is no expectation, if you thought by my questions, that we as family doctors need to be available 5 days a week, including weekends. I'm not in my family practice 5 days a week. So 100%, we all need to build time in our schedule for whatever it may be, our extra hobbies in medicine, within medicine, outside of medicine, vacation. Yeah, we can't be around 24/7 for our patients. I don't see any further questions, so why don't, Susan, if we can just bring up the last slide or two to close out our evening. Perfect. So I just want to let you know about our upcoming session. So on June the 4th, we're going to be having a lawyer come and join us in terms of understanding wills and power of attorney. Okay, secret's out. It's actually my wife coming to speak. I've asked her to come and speak, and just to really share things that she feels that family physicians in the first couple of years of practice really need. I think she gets it. In terms of things that we think we know, but we don't really know. So if you haven't signed up for the session, or if you have colleagues who are interested in signing up for the session, she's really going to let us know about everything that lawyers would charge us the hourly rate to explain to us. And she's really just going to give it to us and we can ask her all the questions. And I'll be moderating that as well. So that should be fun with that back and forth. If you have any questions at all about any of the sessions, previous sessions as well that are posted on our website, you can always send us an email at dfcm.quality@utoronto.ca. If you can move on to the next slide, I think we have one about evaluation, unless this is our last slide. Oh, perfect. So if you could just take a quick moment to complete the evaluation, we're also going to be sending you a link. This is actually really helpful as we plan set sessions for you going forward. We are taking a summer break for our community of practice. So we do have the June session. July and August, we will not be running sessions. But as of September, again, we'll be running sessions for early in practice once a month, as we have been for this whole past year. So on this evaluation, sharing thoughts about this evening, feedback for our speakers, thoughts for future sessions, really does help us plan this for you. So with that, we'll just leave this up on the screen. And again, I really just want to thank all three speakers who have taken time out of their evening. Anthony, I don't know if it's evening where you are in Africa, but thank you as well for taking time out of maybe the middle of the night if you're ahead of us in the world. Thank you to all of them who have taken their time to really share their experiences. And to our speakers, if you're comfortable, there was a question about follow-up contact, putting your contact information in the chat. So I'm also going to share my contact information. Putting that in right now. Yep, and as the early career supports lead, I'm always happy to chat about anything and everything that kind of falls under my portfolio. Anything you guys need literally falls under my portfolio. Feel free to reach out. So thank you everyone for joining us instead of the Leafs game, and have a good evening.